I'm Dr. Divya, and I'm a senior consultant at BLK-Max Super Speciality Hospital, New Delhi, India. And I'm a consultant in Haematology and Bone Marrow Transplant. At our center, we do transplants for both uh, benign as well as malignant conditions related to blood, as well as solid organ tumors. So I will be talking about sickle cell disease. It is a big topic, and I don't think I can do justice to such a big topic in such a short while, but I will try my best to touch every aspect, and we can take anything in detail if required. So starting off very quickly with the history of transplant of sickle cell disease. In 1910, James Herrick, American physician, first described sickle-shaped RBCs. The first transplant in sickle cell disease was performed in 1984, and the wonder drug hydroxyurea came about in 1995.
Ok, d'accord. Donc, on va avoir un petit aperçu sur l'histoire de cette pathologie. La première description de globules rouges en forme de fossile a été décrite en 1910 par James Herrick. Et ensuite, en 1984, la première greffe de cellules souches hématopoïétiques, on peut abrévier comme GCSH, ça a été en 1984. Et puis, en 1995, on a eu hydroxyurie.
So sickle cell disease is a group of hemolytic anemias, and it is an inherited disorder which is called by abnormalities caused by hemoglobin S. And this is a single gene point mutation disease caused by substitution of valine for glutamic acid in the sixth position of the beta globin chain. And all the problems caused by sickle cell disease are due to the properties of this HBS, and that is what causes all these multiple clinical manifestations in sickle cell disease.
Ok. Cette maladie, c'est un groupe de troubles héréditaires avec des anomalies causées par cette HBS, une propre caractéristique c'est caractérisé par le remplacement de valine pour l'acide glutamique dans la sixième position de chaîne bêta-globine. C'est une mutation ponctuelle. Et toutes les propriétés de cette HBS entraînent des manifestations cliniques, y compris des désoxygénations, polymérisation, etc. Et ce sont les effets anti-falciformes.
So as we all know, the half-life of the normal red blood cell is 90 to 120 days, but that of a sickle cell is reduced to 15 to 20 days. And it is not just this short half-life and increased destruction of the red blood cell. It is the shape and the stickiness of the red blood cell which causes it to get destroyed very quickly and cause a lot of issues with these patients.
Alors, la demi-vie de cette cellule drépanocytose dure entre 15 à 20 jours, contrairement aux cellules normales. La destruction accrue par le rate ou le spleen, on peut dire, en raison de sa forme et de sa viscosité. Il y a des anémies en cours, hémolyse, ainsi que toutes les complications aiguës et chroniques affectant plusieurs organes dans notre corps. Et les spléniques, infarctus, asplénine, chronique anémie. Et il y a aussi un risque d'infection à cause de cette pathologie.
Quickly going into the genetics and the transmission of this disease, it is an autosomal recessive inheritance where two affected carrier parents can transmit the disease to their children. There is 25% chance of a child getting the disease, 25% chance of a child being completely normal, and 50% of the child having the same carrier status as the parents.
Alors, cette pathologie se caractérise par une génétique autosomale héritage récessif. Dans ce cas-là, il y a des porteurs pères et aussi porteuses mères. Et il y a 25% des chances que les enfants ne sont pas affectés. De même côté, aussi 25% qui peuvent être affectés. Et aussi, on a 50% de la chance qu'ils sont non pas affectés par cette carrière, cette porteur.
Coming to the geographical distribution of disease, it is occurs actually worldwide. The maximum incidence and prevalence being in sub-Saharan Africa, as well as the Caribbean areas. There is Latin America, which is affected, the Mediterranean countries, the Middle East, and the Indian subcontinent.
Alors, cette propagation de la drépanocytose est très, très énorme partout dans le monde, on peut dire. Plus précisément, ça touche tous les pays africains. On a les Sud-Américains, les Caraïbes, les régions méditerranéennes. Mais l'Afrique est particulièrement grandement touchée, même les régions subsahariennes en Afrique et aussi le subcontinent d'Indien. La fréquence est beaucoup plus grave.
So looking at the sickle cell gene, on analysis of the DNA polymorphism, 4 types of sickle haplotypes are prevalent in Africa, depending upon the geography. It is the Senegal, the Benin, Bantu, and the Cameroon. Whereas in the Indian and the Arabian countries, the Arabian Indian haplotype is more prevalent. The disease with this is milder as the hemoglobin, the fetal hemoglobin is higher in these patients.
Alors, il y a 3 catégories types de fossiles en Afrique. On a en Sénégal, Afrique de l'Ouest Atlantique, on a Bénin, Afrique centrale de l'Ouest, on a Bantou, Afrique centrale et aussi Cameroun. Mais cependant, dans les Arabes indiens, là, la maladie est un peu plus légère, bénigne, grâce au niveau de hémoglobine qui est plus élevé dans leur sang.
Coming to the pathophysiology of the disease. So this single gene mutation causes the hemoglobin S to polymerize. So this polymerization does not happen when the conditions are favorable. So whenever there is an oxygen desaturation, so the hypoxic conditions, acidosis, patient is dehydrated, has an infection, has fever, all this causes the hemoglobin S to polymerize and then results in problems like increased hemolysis. So the cell breaks down, resulting in increased jaundice, which is hyperbilirubinemia. The increased abnormal erythrocyte flow. So the red blood cells become more sticky and the flow through the vessels get affected. They also become adherent to the endothelium of the vessels, and the nitric oxide availability reduces. This causes vasoconstriction. So all these factors collectively cause tissue ischemia, and this leads to various issues with sickle cell disease, which includes the pain crisis causing end organ damage, such as that to the chest, where we can have acute chest syndrome, cerebrovascular diseases in the brain, strokes, there can be pulmonary hypertension, the eyes can be affected, the skin can have ulcers. So various organs can be affected due to this continuous alternate cycles of ischemia and reperfusion due to this abnormal hemoglobin.
Alors, à cause du hémoglobine anormal, il y a un changement avec le processus de polymérisation de l'hémoglobine. Donc, à cause de ce processus, il y a une possibilité que beaucoup de conséquences soient là. Avec cette polymérisation de l'hémoglobine, on peut voir ici, on a l'hémolysis anormale, hétérocytie, rhéologie, cellulaire addition, etc. Donc, en tout cas, en bref, à cause de cette polymérisation normale d'hémoglobine, ça se traduit par des dommages de tous des organes. On a par exemple, on a des ulcères de la peau, il y a des maladies cérébrales, vasculaires, hypertension pulmonaire, par exemple. Donc, en tout cas, à cause de ces symptômes, avec des déshydratations, de la fièvre, etc., ça traduit par des conséquences assez graves.
Coming to sickle cell trait. So basically, sickle cell trait, people are not having any disease. They are just carriers. So the hemoglobin S in these people will be approximately 40%. Their lifespan is completely normal, except few medical issues may occur in high altitude conditions, such as some splenic infarctions. They're also at a higher risk of renal medullary carcinoma in comparison to patients with sickle cell anemia.
Alors, les patients ou des personnes qui souffrent du trait drépanocytaire, c'est pas forcément une maladie. Là, on a des CBC, des NFS normales. Les nombres de réticulocytes, ils sont aussi normaux. Les frottis sanguins, c'est aussi normal. Alors, tous les éléments sont normaux. Alors, les espérances de vie, ça aussi peut être normal, mais avec pas de problèmes médicaux. Par exemple, hyposténurie, hématurie. On a aussi une augmentation du risque d'infection urinaire pendant la grossesse. Aussi, il existe un risque d'infarctus splénique sévère en haute altitude. C'est quelque chose d'important à retenir. Et à la fin aussi, on peut trouver les carcinomes médulaires rénales. Donc, ce n'est pas forcément une maladie, mais évidemment, avec un peu de problème, ce sont les signes à respecter.
So the various genotypes which cause sickling complications, along with the sickle cell disease, if there is coexistence HBC disease, thalassemia, HBO Arab or HBD Punjab, all these can cause sickling complications, as well as having a concurrent alpha gene deletion.
Alors, il y a dans cette maladie, on a des complications de la falciformation. Ça peut se traduire avec des HBSS, c'est-à-dire anémie falciforme. On a d'autres éléments comme HBSC avec thalassémie, par exemple, et d'autres éléments comme ça. Ça peut être aussi associé à des délétions concomitantes des gènes de la globine alpha, par exemple.
So coming to the lab diagnosis of sickle cell disease, a peripheral smear is very important in the diagnosis. And I will show you a picture where you can see these sickle cells.
Alors, je montre ici une petite image dans laquelle on peut trouver des petites cellules qui sont anormales. Donc voilà, c'est le diagnostic qui se passe dans le laboratoire.
Other diagnostic tests for sickle cell disease include a sickle solubility test. And in this, the polymerization of HBS is seen after adding a reducing agent, but it will see only sickle cells. So we cannot differentiate between a patient who has sickle cell disease or a carrier, which is AS. And the other hemoglobin analysis with hemoglobin HPLC, which is the high performance liquid chromatography, isoelectric focusing, and gel electrophoresis are other confirmatory diagnostic tests.
Alors, il y a des tests de diagnostic. La première, c'est le test de solubilité des drépanocytes. Là, on a la première, la polymérisation de HBS par l'ajout d'un agent réducteur. Deuxième, on a positif pour SS ou AS. Alors ici, c'est un peu difficile, c'est un peu compliqué de distinguer de celui qui est infecté par cette pathologie et celui qui seulement les porteurs. La deuxième analyse, c'est l'analyse de hémoglobine. Ici, on ajoute un peu de liquide, chromatographie avec une haute performance. Aussi, on a focalisation isoélectrique et le troisième, c'est électrophorèse sur gel. Donc, ce sont les liquides un peu plus performants pour vérifier, pour diagnostiquer cette pathologie existe ou non dans le corps.
So differentiating between different sickle cell disease phenotypes and sickle cell trait can be done looking at the clinical severity, the hemoglobin S percentage, the hemoglobin A percentage, the hemoglobin, the MCV, and the reticulocyte count.
Alors, ici, on peut faire le trait selon les chiffres, le pourcentage pour comprendre. On a différents critères que les gravités cliniques. Par exemple, le premier, c'est HB avec S. On a deuxième HB avec A. Et aussi, on a l'hémoglobine avec G et DL.
So very important for diagnosing and early diagnosis and reducing the morbidity and mortality of the disease is neonatal screening. So this is a heel test which is done. It is a heel prick test where one spot of blood is taken out at birth, and this is able to give us a screening test, but definitely a confirmatory test is required if we suspect sickle cell disease.
Alors, ici, cette image correspond à dépistage néonatal. Alors, ce test est hyper important. C'est un diagnostic précoce. Améliore à la fois la morbidité, aussi améliore la morbidité et aussi la mortalité. Alors, il y a une prise de sang provenant d'une piqûre sur le talon. Ici, on se concentre plutôt sur le talon de bébé. Et ça est utilisé pour différentes maladies génétiques, pour comprendre. Ça, il détermine quoi exactement? Il détermine la quantité d'hémoglobine normale dans le tâche de sang. Mais alors, il faut faire attention que le test de confirmation, c'est hyper important. On ne peut pas déduire si un bébé est un patient ou non de cette pathologie. Donc, c'est juste pour dépister, mais alors, il faut quand même faire le test de confirmation.
Now, this is a cartoon showing all the acute and chronic complications which occur in sickle cell disease. So I will be going through these briefly, starting from the brain, the acute complications. So a meningitis or stroke. Coming to the eyes, retinal infarction can occur. The chest can have acute chest syndrome. Besides this, acute pain crisis can occur at any point. Sepsis, gallstones, sickle hepatopathy, papillary necrosis in the kidneys, splenic infarction and splenic sequestration, priapism in males, and osteomyelitis of the bones. So all of these are acute complications. And then coming to the chronic complications, again in the brain, with time, recurrent strokes can cause neurocognitive dysfunction. It can also cause retinopathy. In the lungs, pulmonary hypertension, cardiomegaly in the heart, leading to diastolic heart failure eventually. The kidneys can have albuminuria and as well as slow diminishing GFR. The spleen undergoes multiple infarcts, and there is functional asplenia by the age of 2 to 3 years in children. There can be delayed puberty, erectile dysfunction, skin ulcers, avascular necrosis of the bones, and of course, chronic pain.
Alors, ici, on s'intéresse aux complications aiguës et aussi chroniques de la drépanocytose. Toutes les complications aiguës sont en jaune, ici on peut voir. Donc, en bref, on ne peut pas tout toucher, mais quand on commence avec le cerveau, on peut voir ici, ça entraîne les méningites, Puis, il y a dans les yeux, on a l'ischémie postérieure glaucome. Puis, dans le foie, puis on a dans les reins, on a c'est isoténurie. Comme ça, dans les cœurs, dans les poumons, dans tous les organes ici, on peut voir il y a des complications aiguës. Par contre, on a aussi des complications chroniques qui sont hyper importantes. Pour le cerveau, on a dysfonction neurocognitive. C'est assez compliqué. Puis, pour le poumon, on a l'hypertension pulmonaire. Puis, pour les reins, on a d'autres maladies, par exemple les alcophénies fonctionnelles, etc. Il y a des ulcères de la peau et aussi de la douleur chronique. Donc, en tout cas, on peut voir ici, il y a tant de complications aiguës ou chroniques qui touchent presque tous les organes dans le corps.
The next few slides are almost repetition of the complications, so I will not go through them in detail. So going briefly into the acute complications of sickle cell disease.
On va brièvement toucher les complications aiguës.
So acute painful episodes, these are the vaso-occlusive crisis, which is the biggest problem in patients with sickle cell disease and the most common clinical complication. So this happens, as we already know, due to the entrapment of the red cells. These cells are sickle-shaped, so they go and occlude the capillaries. And while this is happening, there is also release of a lot of inflammatory mediators. All of this contributes to the pain and the recurrent cycles of ischemia and reperfusion. Unfortunately, 1/3 patients have pain almost daily. Most of them learn to manage the pain at home, but for severe refractory pain crisis, they may need admission. These may last for sometimes as long as 2 weeks. And the triggers often for these problems, these crises, are either very cold temperatures, dehydration, infections, fevers, or any sort of stress.
Alors, des douleurs aiguës, il y a beaucoup d'épisodes de douleurs aiguës et franchement, c'est assez douloureux. Alors, donc, quand on se concentre sur la douleur, c'est la complication la plus commune dans cette pathologie. Puis, quand on avance au les piégeages microvasculaires des globules rouges, il y a occlusion des capillaires et recrutement de médiateurs inflammatoires. Donc, ce sont les caractéristiques des douleurs assez aiguës. On a aussi des cycles d'ischémie et de reperfusion. Alors, c'est tellement triste de voir que ces épisodes de douleur durent environ 2 semaines et c'est tellement pénible pour tous les patients. Un tiers des patients ressentent une douleur quotidienne. Et quelles sont les causes qui entraînent cette douleur? C'est plutôt le froid, la déshydratation, le stress, les infections. Donc, c'est quelque chose qui dure assez longtemps.
Management of these acute pain episodes. So most important, we used non-steroidal anti-inflammatory drugs as the first line. They may also need subsequent opioid medication. And if the pain is not resolved, then we can consider ketamine infusion or regional anesthesia. This is for refractory pains. Other non-pharmacological therapies like massage, yoga, etc. may also be used. However, the other supportive treatment like oxygenation, hydration, looking for a source of infection and treating it with antibiotics, incentive spirometry, all of these help. And in simple pain crisis, blood transfusion is not indicated.
Alors, pour les épisodes de douleur, douloureux, comment effectuer la prise en charge. Donc, le contrôle rapide de la douleur, c'est la première étape. On a des services d'urgence, délai entre l'arrivée et la première dose d'oncologique, ça dure 60 minutes. Puis, on a aussi les réévaluations fréquentes, toutes les 30 et 60 minutes. On a, pour supporter, on a des médicaments oncologiques opioïdes par voie intraveineuse, posologie adaptée, donc c'est important, basé sur les doses de départ et antérieures. Et aussi, on a envisagé une perfusion de kétamine ou une anesthésie régionale pour les douleurs réfractaires. Aussi, pour traiter cette douleur, on a aussi des thérapies non pharmacologiques, par exemple des massages ou des yoga, exemple. D'autre part, pour rechercher une infection, comment retrouver d'autres facteurs déclencheurs, on a aussi des antibiotiques empiriques. On a les spirométries incitatives, oxygène en cas d'hypoxie, c'est hyper important. Et à la fin, on a la transfusion sanguine. Donc, c'est non indiqué dans les épisodes douloureux non compliqués.
The second most common cause of hospital admissions in sickle cell disease is acute chest syndrome, and this is the leading cause of premature death. Recurrence rate, unfortunately, is also quite high. It is 80%. So the diagnosis is made by looking at acute pulmonary infiltrates, and very often the X-ray picture is delayed by almost 12 hours. And they present typically just like a pneumonia with fever, chest pain, shortness of breath, cough, reduced saturations. And onset is often 24 to 72 hours of an acute pain episode.
Alors, le syndrome thoracique aigu, c'est la deuxième cause la plus fréquente de hospitalisation chez les patients atteints de drépanocytose. Et aussi, c'est la première cause de décès prématuré avec le taux de récurrence avec 80%. Aussi, il y a des retards avec des radiographies et généralement dans les cas, 24 heures, 92 heures suivant un épisode douloureux aigu.
The causes of this chest syndrome is usually infection of the lungs, can also be embolism, fat, pulmonary, and hyperventilation. The investigations are the regular, the CBC inflammatory markers, a blood gas, cultures of the blood, X-ray. And as I said, the radiological sign usually lag behind the physical signs.
Cet syndrome, quelles sont les causes? Les causes sont les infections pulmonaires, embolie grossieuse, hypoventilation avec la douleur, chirurgie et aussi opioïdes. Par rapport aux examens, on a les NFS, les marqueurs inflammatoires, etc. Alors, gaz du sang artériel, oxymétrie de pouls. Il y a une petite remarque, les signes radiologiques sont généralement en retard par rapport aux signes cliniques. Donc, c'est quelque chose d'assez étonnant.
So this is a very busy slide, but it just recapitulates whatever I said before, that we treat these chest crisis with IV fluids, oxygenation, relieving the pain and controlling the pain crisis first, giving antibiotics adequately, doing incentive spirometry, closely monitoring the patient. And if there is a progression in the pneumonia, the saturations do not settle, there are increasing oxygen demands, then there may be need to transfuse blood. And of course, if the situation worsens and does not settle over 12 hours, we may consider a red cell exchange depending upon the clinical situation.
Alors, la prise en charge d'un syndrome thoracique aigu suspecté. Tout d'abord, on passe aux examens initiaux comme les NFS, comptage des réticulocytes, hémoculture, dépistage des virus, oxymètre, etc. Et après, on a les traitements initiaux avec la perfusion de IV, rétablissement de volume, soulagement de la douleur, les antibiotiques, oxygène pour maintenir une saturation, etc. Et après, si il y a une concentration, une propagation de, de ces éléments, on passe par la transfusion sanguine avec une hémoglobine inférieure de plus de 2 par rapport à la valeur de base de 11. Et si oui, à la fin, on fait la transfusion à une à deux unités. Sinon, on va continuer la prise en charge de la douleur.
Prevention of the acute chest syndrome. So in primary prevention, what we can do is control the pain crisis by managing it optimally, monitoring the patient very closely, doing incentive spirometry, and preemptively treating all infections. And in secondary prevention, the most important is starting hydroxyurea and considering chronic transfusions.
Alors, quelles sont les préventions, les actions mises en place pour la prévention? La prévention primaire, on a la prise en charge optimale des crises douloureuses, niveau élevé de vigilance, spirométrie incitative et traitement préventif. Le secondaire, on a hydroxyurie et la transfusion chronique. Quels sont les résultats? Ça peut arriver au décès de 3%, événements neurologiques avec 11%, et le mauvais pronostic sinon détecté ou traité tardivement.
Coming to the next complication of a sickle cell disease, that is stroke. Stroke is a devastating complication, and in children, hemorrhagic strokes are more common than ischemic strokes.
Alors, dans cette pathologie, dans cette pathologie, on a cette condition de EVC. C'est une complication assez fréquente et dévastatrice de la drépanocytose. On a des types ischémiques et aussi hémorragiques. Et ça dépend du risque selon l'âge.
So again, the risk factors for the ischemic stroke and sickle cell disease are the conventional risk factors like hypertension, diabetes, dyslipidemia, AF, renal disease. All of this leads to CNS vasculopathy. And these can cause ischemic injury in sickle cell patients. Other causes where hemoglobin is reduced, causing oxygen saturations to reduce, and increased oxygen demands like the acute chest syndrome, fever, seizures, all can lead to stroke. Then any relative anemia, any acute anemias where sudden fall in hemoglobin, or such as in the aplastic crisis, like with infection of parvovirus B19, all can lead to ischemic injury in sickle cell. Increased cerebral blood flow causing reduction in the cerebrovascular reserve also causes chances of ischemic injury.
Alors, les lésions ischémiques dans la drépanocytose, premièrement, on a des facteurs plus de flux sanguin cérébral avec les réserves cérébrovasculaires. On a des hémoglobines basales faibles et aussi un pourcentage plus élevé. Deuxième, on a des facteurs de risque conventionnels, comme par exemple hypertension, diabète sucré, hyperlipidémie, fibrillation auriculaire, etc. Puis le troisième, ça peut se traduire sur la vasculopathie du SNC. Là, on a occultation, dissection, maladie de Moya-Moya, etc. Cette anémie aussi, c'est relative et aiguë. Donc, on a des hémoglobines basales assez faibles avec une chute aiguë relative de hémoglobine et un peu d'infection par le parvovirus. La saturation en oxygène de l'hémoglobine et plus de demande en oxygène, c'est important. Oui.
So now this is a pie chart which depicts the prevalence of overt strokes and silent cerebral infarcts in children who were born and followed up for 18 years in sub-Saharan Africa as well as in India, where primary prevention was not routinely practiced. This showed 11% children to get stroke and 39% to get silent cerebral infarcts. So these are children who did not receive primary prevention.
Alors, c'est un diagramme circulaire ici. On peut voir que cette figure montre que la prévalence des EVC et des SI chez 1000 enfants nés avec la drépanocytose, suivis pendant 18 ans dans les pays d'Afrique subsaharienne et en Inde, où la prévention primaire n'est pas pratiquée couramment. Cela repose sur une hypothèse selon laquelle 11% auront un EVC et 39% présenteront des SSI avant leur 18e anniversaire. Donc, c'est la situation.
This graph shows the age of the first cerebrovascular accident in sickle cell disease patient by the genotype. So patients with sickle cell disease, sickle cell anemia had a 24% chance, and those with SC disease had a 10% chance of having a stroke by the age of 45 years.
Cette infographie nous montre l'âge avec les premières, dans le premier temps avec cette pathologie, selon les génotypes par les génotypes. 24% des individus avec les SS et aussi 10% des individus avec les pathologies SS. Et ils ont eu cette pathologie avant l'âge de 45 ans.
So the risk factors for stroke, monitoring of the transcranial Doppler velocities must be done regularly, and any abnormality is a risk factor for stroke. Besides this, increasing age, hypertension, previous history of a TIA, a silent cerebral infarct, or chronically low hemoglobin, and also HBSS disease. All of these are risk factors for stroke.
Alors, quels sont les facteurs de risque de EVC? D'abord, on a vitesse anormale au Doppler transcrânien pédithérique, infarctus cérébral silencieux, puis on a antécédent d'accident ischémique transitoire, faible concentration d'hémoglobine à l'état stable, âge avancé et aussi l'hypertension.
So coming back to the transcranial Doppler velocity screening for children, as we know that stroke due to stenosis or occlusion of the internal carotid or the middle cerebral artery occurs due to this occlusion. And the transcranial Doppler predicts the risk of stroke in children. So all velocities less than 200 are safe, and they will keep the child stroke-free for 36 to 40 months.
Alors, on va s'intéresser ici à Doppler transcrânien, TCD. C'est le dépistage des risques chez les enfants. Première, AVC dû à une sténose ou à une occlusion de l'artère carotide interne ou cérébrale moyenne. Deuxième, on a le TCD qui prédit le risque d'AVC chez les enfants atteints de drépanocytose. Avec les vitesses au TCD moins de 200 cm, probabilité de rester sans EVC pendant 40 mois et 93% chez les enfants.
So the primary prevention in children for stroke can be done by monitoring the TCD and long-term blood transfusions to reduce the hemoglobin S to less than 30% is helpful. It reduces the risk by 92% for overt stroke. There were the STOP-1 and the STOP-2 trials in 1998 and 2005 respectively. And the STOP-1 trial helped in the first overt stroke prevention, and it suggested keeping the hemoglobin less than 30% by regular PRBC transfusions. The STOP2 trial in 2005 also suggested stopping prophylactic PRBC transfusions after 30 months. But this showed that there was again high risk of strokes. And therefore, it is suggested that regular transfusions must be given for primary prevention in children. So the ASH guidelines in 2020 suggest for children with HBSS and HBS beta 0 disease to do annual transcranial Dopplers after the age of 2 up to 16. And if they are abnormal, regular transfusions must be done to keep hemoglobin S less than 30% or hemoglobin more than 9 grams for at least 1 year. After 1 year, if we decide to stop, we can consider starting hydroxyurea at the maximum tolerated dose. This is the Twitch trial, which came about in 2016.
Alors, EVC dans les drépanocytoses, c'est prévention primaire chez les enfants. Le TCD, c'est-à-dire Doppler transcrânien chez les enfants, prédit le risque d'EVC. Alors, les transfusions sanguines à long terme, pour maintenir le HBS moins de 30%, c'est important, avec le but de réduction de 92% du risque d'EVC manifeste. Et les programmes STOP 1 et STOP 2. Les recommandations de l'âge 2020 chez les enfants avec HBSS et HBS beta 0. Ici, le TCD annuel âgé de 16 ans. Si TCD anormal, il est recommandé de faire des transfusions régulières pour maintenir moins de 30% entre les enfants entre 2 et 16 ans. Et après un an, si après un an l'arrêté de transfusion est envisagé, considérez l'hydroxyurie à la dose maximale tolérée.
The secondary prevention of strokes and sickle cell disease is again to maintain chronic transfusion programs. The goal is to maintain hemoglobin S less than 30%, as discussed before, and hemoglobin to be more than 9 grams. 23% of the children, unfortunately, get a second stroke despite a chronic transfusion program.
Alors, quelles sont les mesures de prévention secondaires? La première, c'est maintenir la transfusion chronique, le programme de transfusion chronique, le but, de moins de 30% et HBS est plus de 9 grammes. 23% des patients pédiatriques auront tout de même un deuxième AVC malgré le programme de transfusion. Alors, chez les adultes, par contre, on a le programme de transfusion chronique comme ci-dessus et dépistage et prise en charge de l'hypertension, du diabète et de l'hyperlipidémie.
This is the STOP 1, STOP 2, and the Twitch trial that I spoke about earlier.
Il s'agit de STOP 1 et STOP 2.
The silent cerebral infarcts, they are also common and they increase with increasing age. The prevalence in children is around 40% and adults is 50%. They are associated with cognitive impairment, poor school performance, and future cerebral infarcts. And the ASH again recommends doing a one-time MRI in all school children and adults. Management of these silent cerebral infarcts can be done with regular transfusions and also regular cognitive evaluation of the children.
Alors, infarctus cérébro-silencieux, c'est assez fréquent et augmente avec l'âge. La prévalence, c'est 39% chez les enfants et 50% chez les adultes. Ça c'est associé au déficit cognitif, mauvaise performance scolaire, risque futur d'infarctus cérébraux. Quelles sont les recommandations de l'ASH? Une IRM unique comme dépistage pendant les premières années de scolarité chez les enfants et les adultes. La prise en charge chez les enfants, c'est les transfusions régulières, préviennent la progression des ICS et des AVC manifestes. évaluation cognitive et chez les adultes, pas de données disponibles aujourd'hui.
Coming to the next acute complication, which is the bacterial infections. So as we know, functional asplenia develops by the age of 2 to 3 years. I think this is a typo. It is not month, it is years. And the risk of encapsulated bacterial infections, especially Streptococcus pneumoniae, increases due to the spleen not functioning. This happens because of recurrent splenic infarcts, and by a couple of years, the splenic tissue is almost dead. So the complications with these bacterial infections can cause septicemia, meningitis, osteomyelitis, and what we can do to prevent these is the conjugate pneumococcal vaccine can be given, and apart from the other vaccines, also start penicillin prophylaxis as soon as possible. And these patients are also susceptible to Salmonella, Haemophilus influenza, meningococcus, and Mycoplasma infections.
Alors ici, on s'intéresse aux infections bactériennes. Le premier point, c'est la spleen fonctionnelle. Ça se développe à l'âge de 2-3 ans. Ici, c'est pas une erreur, c'est pas 2-3 mois, c'est 2-3 ans. Alors, il faut faire attention à ça. Il y a un risque d'infection bactérienne encapsulée, notamment Streptococcus pneumoniae. Quelles sont les manifestations? On a des septicémies, méningite, gîte, ostéomyélite. Il y a une réduction de la mortalité infantile grâce au dépistage néonatal, etc. Mais autres agents pathogènes susceptibles sont Salmonella, Haemophilus, influenza B et Mycoplasma.
Splenic sequestration is the other acute complication. Vaso-occlusive crisis occurs within the spleen, and as a result of which, the red cell pooling can happen within the spleen. This is a hypovolemic shock situation, and it is an emergency. It usually occurs in young children. It can present with left upper quadrant pain, fullness, and a sudden fall in hemoglobin by more than 2 grams, reticulocytosis, and of course, splenomegaly. The treatment for splenic sequestration is just transfusion. And here we have to be careful that we don't transfuse very quickly, because hemoglobin rise suddenly causes increase in hyperviscosity, which may worsen the situation, as well as take care about the volume overload.
Alors, la séquestration splénique, ici, quel est le mécanisme? On a la vaso-occlusion avec accumulation des globules rouges dans le rate. Chez les nourrissons avec HBSS, c'est fréquent, survient généralement avant l'âge de 2 ans. Alors, il y a une urgence avec un choc de hypovolémique. Chez les adultes, ce sont les formes plus légères. Quelles sont les présentations cliniques? On a douleur au quadrant supérieur gauche, sensation de plénitude, sensibilité, etc. Par rapport au traitement, la transfusion, il est conseillé de faire une unité à la fois. Il faut éviter le surcharge volumique, sinon ça va se traduire par une hyperviscosité. Il faut éviter ça.
The liver also gets affected in sickle cell disease. Firstly, due to the sickling process, where there is acute sickle hepatic, which is called the acute sickle hepatic crisis. Then hepatic sequestration can also occur just like the spleen. And there can also be sickle intrahepatic cholestasis, where the sickling is happening in the hepatic sinusoids. Then the second way in which the liver can get affected is due to the multiple blood transfusions. This can lead to infections, hepatitis B and C. And apart from this, other issues of the liver include thrombosis, Budd-Chiari syndrome, hepatic abscess, and cholelithiasis.
Alors, quels sont les des hépatopathies aiguës liées à la drépanocytose. Alors, dû au processus de falsification, la première, c'est crise hépatique drépanocytaire aiguë, séquestration hépatique et cholestase intrahépatique drépanocytaire. La deuxième rubrique, c'est dû à des transfusions sanguines multiples et ça va résulter aux hépatites virales B et aussi C. D'autres facteurs divers sont les coélithièses, syndrome de Budd-Chiari et abcès hépatique au bilion.
Management of this hepatopathy depends upon the clinical scenario. For example, gallstones will be treated with cholecystectomy. Acute sickle hepatic crisis, we need to do supportive care and consider red cell exchange if the situation worsens. In hepatic sequestration, blood transfusion and supportive care. In sickle cell intrahepatic cholestasis, again, supportive care and must consider red cell exchange depending upon the clinical situation.
Alors, la prise en charge, ça dépend des scénarios cliniques et quelles sont les recommandations. Premièrement, si on a les calculs biliaires, c'est quelles sont les recommandations, c'est coller cystomomie. Deuxième, si on a les crises hépatiques drépanocytaires aiguës, on a les solutions, soins de soutien, ou aussi l'échange des cellules. Puis, séquestration hépatique, la transfusion et soins de soutien. Et quatrième, cholestase intrahépatique drépanocytaire. Là, on a aussi, encore une fois, soins de soutien complet et échange transfusionnel.
The kidney is affected by this disease as well. So the renal papillary necrosis may occur due to recurrent medullary infarctions. And this occurs in around 15 to 30% of individuals with sickle cell disease. It may present as painful or painless hematuria, and it can be complicated with a UTI or obstruction. The treatment over here is hydration, alkalinizing the urine, and treating the infection if it is present, and relieving any obstruction. There can also be acute renal failure. This may occur due to any acute pain episode, chest crisis, or be a part and parcel of multi-organ failure. And close monitoring of the creatinine daily intake output is very important to avoid nephrotoxic drugs, and definitely the involvement of a nephrologist is required.
Alors, les complications rénales aiguës se présentent dans deux formes. La première, c'est nécrose papillaire rénale. Là, ça dû à un infarctus médullaire. Ça survient chez 15 à 30% des individus atteints de drépanocytose. Il y a aussi les présentations cliniques, hématurie indolore ou douleur au flanc avec hématurie. Ça peut aussi être compliqué par une infection urinaire. Quels sont les traitements? On a hydration, alcanisation des urines, arrêt des médicaments nocifs, etc. Aussi, l'insuffisance rénale aiguë, c'est le deuxième. Ça peut survenir lors d'un épisode douloureux aigu, d'un syndrome thoracique aigu SCS qu'on a vu avant, ou d'une défaillance multiviscérale. La prise en charge, c'est hyper important. Surveiller la créatine et les apports et sortie de liquide quotidien et éviter les néphrotoxines.
Acute ocular complications. This includes the central retinal artery occlusion. It is an ocular emergency. It is more common in children and young adults, and it presents with sudden vision loss. And the treatment over here is again either a simple transfusion or an exchange transfusion. The other ocular complication can be orbital infarction. This can occur during a vaso-occlusive crisis, and it may present as protrusion of the eye pain, sudden lid and orbital edema. Treatment over here is IV fluids, pain control, and steroids.
Alors, quelles sont les complications oculaires aiguës? La première, c'est occlusion de l'artère centrale de la rétine. Là, c'est vraiment une urgence ophtalmologique. C'est plus fréquent chez les enfants et jeunes adultes atteints de HBSS. La présentation, il y a une perte soudaine de la vision. Traitement, c'est transfusion simple ou échange transfusionnel. On a aussi, d'autre côté, infarctus orbitaire. Ça peut survenir lors d'une crise vaso-occlusive, VOC. La présentation, c'est protrusion de l'œil, douleur oculaire, odème des paupières. Traitement, c'est perfusion intraveineuse, IV, gestion de la douleur stéroïde.
Priapism, this is sustained, unwanted, painful erection lasting for more than 4 hours. And venous occlusion occurs, causing decreased venous outflow. It's extremely painful condition. Severe or recurrent priapism can lead to permanent erectile dysfunction. So lifetime prevalence in boys and men is 30% to 89%. And the treatment here is supportive with IV hydration and pain management. Vasoactive agents like pseudoephedrine have been used. And if it is prolonged, then a urology consult must be taken so that some surgical intervention may be done to give the relief.
Alors ici, on s'intéresse au priapisme. Là, ça caractérisé par une érection prolongée, non désirée et douloureuse durant plus de 4 heures. Vaso-occlusion entraînant une diminution de l'écoulement veineux, souvent extrêmement douloureux. Le priapisme sévère ou récurrent peut entraîner une dysfonction érectile permanente. Et ça prévalent au cours de la vie chez les garçons et les hommes de 29 à 89%. Quels sont les traitements? Premièrement, c'est soutien, hydration IV, gestion de la douleur. On a des agents vasoactifs oraux et avec prolongé, consultation en urologie, soulager les syndromes des loges, améliorer les flux sanguins.
Acute aplastic crisis. This is due to parvovirus B19 infection. And it is again common in children with HBSS. And it presents as sudden onset fatigue, shortness of breath, fever, syncope. Hemoglobin may fall by 3 to 6 grams suddenly from the baseline. The reticulocytes are also decreased in this case. Treatment is supportive care along with red blood cell transfusion. And the only thing to be noted is that lifelong immunity occurs, so it does not reoccur.
La crise aplasique aiguë, c'est dû à une infection par le parvovirus B19, plus fréquente chez les enfants atteints de HBSS. Présentation, on a apparition progressive de fatigue, fièvre, syncope, etc. Hémoglobine entre 3 ou 6 grammes, diminution par rapport à la valeur de base. Quels sont les traitements? Transfusion de globules rouges en soutien. Immunité humorale à vie, donc ne récidive pas.
In the interest of time, I will go very quickly through the chronic complications because I think we will not be able to complete the management part otherwise. So chronic complications, there is pulmonary arterial hypertension. I don't know how the interpreter would like to do this. Neha, are you there? Okay. So pulmonary arterial hypertension.
Dr. Divya, this is Varun. I mean, you can continue with English. We will share the French slide with the French audience later on, just in the interest of the time. Please go on.
Okay. In chronic complications, there are chronic renal complications, which, as I had mentioned before, results in presents with albuminuria and protein. Because of this recurrent loss of protein, nephropathy may result, causing reduced GFR, and finally resulting in end-stage renal failure, needing renal replacement therapy. Renal medullary carcinoma, I have already mentioned with respect to sickle cell trait patients. Prognosis here is poor. Chronic sickle hepatopathy, just like the acute, the same causes, sickling process, multiple transfusions, and other miscellaneous causes. sickle retinopathy can also occur chronically. For this, there is a annual screening of the retina is suggested, and the treatment here is laser photocoagulation or vitrectomy. Avascular necrosis, very important chronic complication of sickle cell disease, not just affects the hip, but also can affect the shoulder, knees, feet, back. And MRI has very high sensitivity and specificity to pick up this complication. And the management can initially be to control the pain, and eventually, if it does not settle, may need some sort of orthopedic intervention. Very important, the transfusion iron overload. Patients who are needing chronic transfusions end up building up a lot of iron overload. And so for this, we need to look at the ferritin levels every 3 monthly. If the ferritin is more than 1,000, we suggest to do a liver MRI. And over here, the liver iron content can be measured. And if it is more than 7 milligrams of iron per gram dry weight of the liver, iron chelation should be started. And if it is more than 15, then a T2 star MRI to look at the heart for iron overload must be done. And the cardiac function should be assessed. Now coming to the treatment of sickle cell. So first going to the general medical care. So the vaccines, as I already discussed briefly, the pneumococcal every 5 years, the influenza vaccine annually, the hepatitis A, B are required, an annual examination of the eyes to check for retinopathy, looking at the nutrition, blood pressure control. As we've already seen, all these risk factors contribute to the risk of stroke. Then the pain management we have discussed in detail, acute and chronic both. Then screening and managing all acute and chronic complications. So the disease modifying therapy in sickle cell is transfusions for sure. Then hydroxyurea, L-glutamine, I will discuss in detail in a bit, crizanlizumab, and voxelotor. Then the only curative therapy for sickle cell disease is basically hematopoietic stem cell transplant. Gene therapy is also under a trial. So there are multiple benefits of hydroxyurea. I had called it the wonder drug. So it not only increases the fetal hemoglobin, it also reduces the neutrophil and the reticulocyte counts. It also decreases their adhesiveness, improves the RBC hydration, and thereby decreases sickling, and also causes release of a nitric oxide, and therefore causes vasodilation of the vessels, relieving the pain. So hydroxyurea recommended to reduce pain crisis, chest crisis. It reduces blood transfusion and hospital admissions, and it has been given long-term. It is quite a safe drug, starting from a minimum of dose of 10 mg per kg must be given to all patients to reduce these awful complications. And there is some literature to say that the incidence of, there was some incidence of malignancy, but we have been using it safely for years. So the indications to start hydroxyurea are more than 3 pain crises a year or more than 2 chest crises. And it can also be considered in patients who have chronic leg ulcers or who have symptomatic anemia with alloimmunization and cannot be transfused that regularly, who have persistent priapism, which is not responding to standard therapy, increased risk of hemolysis and pulmonary hypertension. So hydroxyurea, we can start at a dose of 10 to 15 milligram per kilogram, monitor the CBC, LKFTs, and gradually increase it if required by 5 mg per kg every 2 months. And it is well tolerated. There is literature to say that you can give it to a dose as high as 35 milligram per kilogram. And if toxicities occur, toxicities are GI toxicities like nausea, vomiting, skin hyperpigmentation, pigmentation of the nails, and of course the liver and kidney needs to be monitored along with the CBC. And if toxicities increase, we can stop hydroxyurea, monitor, wait for a couple of weeks, and resume at a lower dose. For patients planning pregnancy, hydroxyurea should ideally be stopped around that time. For males, it can reduce the sperm count and the mobility of the sperms. And it is also teratogenic. So if a female conceives, she must not have hydroxyurea in the first trimester, at least. L-glutamine, basically, this is an antioxidant which may increase the availability of reduced glutathione, and this reduces the oxidative stress, which is contributing to the pathophysiology of sickle cell disease. It was approved by FDA in 2017, and I have no experience of using L-glutamine. Crisanlizumab, this is a human monoclonal antibody. This is against P-selectin addition molecules. And this is a sustained trial which was published in NEJM in 2017. It shows these beautiful curves with high dose, low dose of crenalizumab along with the placebo. And it shows that it looks quite effective in this. It is a 30-minute infusion given every 4 weeks. But I suspect that while they gave this, the patients were also on hydroxyurea. So the third drug which has been used is voxelotor, and this is comes with the brand name of Oxbrite, and it's a hemoglobin oxygen modulator. It increases the hemoglobin and reduces hemolysis. It was approved in 2019 by the FDA, but in September 2024, Pfizer decided to withdraw it voluntarily due to some safety concerns. So again, it is taken orally at a dose of 1500 milligrams per day. Red cell transfusions, they are both simple and exchange. So ours is a tertiary hospital, and we end up doing a lot of red cell exchanges for patients with sickle cell disease, especially pre-operatively, to get the HbS down. So again, a word of caution about transfusing. I've already said it before that every time we transfuse, must keep the hemoglobin 10 or less, because the viscosity of blood will increase if the hemoglobin goes higher than this. And this in turn will increase the sickling process and increase painful episodes. Complications of transfusions are iron overload. I have already discussed. Alloimmunization, again, becomes a problem with sickle cell patients, much more than those with thalassemia that we see. And then there are delayed hemolytic transfusion reactions. So I just mentioned preoperative transfusions. So these can be used for complicated high-risk surgeries to bring the percentage of hemoglobin S down to less than 30% so that the surgery is safe. So coming to bone marrow transplant, this is the curative option for sickle cell disease. And this is the first article published by the NEJM in 1991. So this is a study of parents' decisions. So in the very interesting paragraph where the parents were given a description of what the transplant is going to be like in detail, and they were given the whole process in detail as well as the complications. And then they were presented with a series of hypothetical situations and then asked to answer the percentage of risk mortality they were ready to take in order to obtain a cure for their children. Quite interesting. So a transplant basically can be done with matched siblings, currently matched unrelated, as well as haploidentical stem cell transplants. Over here, there is a data presented with 3 transplant registries showing 1,000 transplants, matched sibling transplants between 1986 and 2013, where the 5-year overall survival for children less than 16 was 95%, and over 15 years was around 81%. And reduced intensity conditioning showed an overall survival of 93%. The indications for transplant are irreversible end organ damage, stroke, elevated TRV, sickle, the kidney disease, sickle hepatopathy, and 2 or more VOCs requiring hospitalization every year, or any single chest syndrome while on hydroxyurea. Apart from transplant, gene therapy is the other approved transformative therapy, and this is done quite in a similar manner to autologous stem cell transplant, where from the patient we collect hematopoietic stem cells. These are sent for either gene addition or gene editing. And after the transduction is done, these modified hematopoietic stem cells are transfused back into the patient after they have received myeloablative conditioning, usually with busulfan. And once the reinfusion of these genetically modified stem cells occurs, we wait for the engraftment, and then the patient is cured. So there are two types. There is gene addition and gene editing, both FDA approved in December of 2023 for children more than 12 years of age. Barriers to gene therapy are the cost, quite prohibitive. And apart from that, there is loss of fertility, secondary malignancies. This is due to the chemotherapy, which is given as conditioning. So that is about the treatment. Thank you so much.
Thank you so much, Doctor. Thank you so much. It was a very wonderful and insightful and informative session. And so we have a few questions that the doctors want to know. I'm going to share the questions on the chat. So
Okay.
it would be great if you could, address those questions. First of all, there's a question on the chat itself. What is the average cost of stem cell transplant?
So it depends upon the type of donor. For a match sibling donor, the cost is around 20 to 24,000 US dollars, whereas it goes up to around 40 to 45 for a haploidentical stem cell transplant.
Okay, great. So the first question is cost implication for bone marrow transplant as a definitive cure for sickle cell disease.
Sorry, can you repeat that?
I've written that on the chat itself also. This is the basically the first question, cost implication for bone marrow transplant.
I just told the cost implications.
Okay.
Yeah.
All right. And what medications should be avoided by people with sickle cell disease? What is the role hydration in sickle cell disease?
So the role of hydration is immense. Anyone who is going to have a pain crisis is having a pain crisis. Hydration really helps. And I don't think in particular there are any diseases to avoid, any medications to avoid in my knowledge. I don't know if there is anything particular they want to know. I can think about it and say.
All right. This was answered by this was asked by Dr. Emmanuel. If Dr. Emmanuel is on call. Okay, let's move to the next question. What are your absolute indications for bone marrow transplant in sickle cell anemic children?
So our indications for transplant are, see, now they are changing every day. Why? Because now the availability of donor after the advent of haploidentical stem cell transplant and the outcome of the transplant has become so good that a lot of families are willing to take the risk. So for us, indications, any child with a single episode of stroke, any child with a single episode of chest crisis, or multiple episodes of pain requiring admission.
All right. So the next question is asked in French. I would tell you the question in English. Aparna, would you please repeat the answer in French, like translate the answer later on? So the question, Dr. Divya, it is, what preventive measures are possible to avoid complications such as avascular necrosis?
I think a repeated pain crisis, but there is no other way. So we have to hydrate, treat the pain crisis, because these, when they become recurrent, they can affect and cause these infarcts in the bones. And unfortunately, sometimes we cannot prevent them.
Alors, malheureusement, il n'y a pas vraiment de méthodologie exacte pour, prévenir cette pathologie. Hydration, c'est hyper importante. Et what is the other point you told me? Apart from hydration, you mentioned some other point. There's no other method, right? You said, which we can prevent this. And anything further? Any other point?
I think hydroxyurea. So fluids, hydroxyurea, supportive care every time there's a pain crisis.
Ok. Chaque fois quand on a la crise douloureuse, l'hydration et l'uroxyrie, ce sont les mesures qui sont possibles pour le traitement, mais on ne peut pas prévenir et faire des mesures préventives.
All right, thank you, Parna. So Dr. Atanda, he has written on the chat a few questions. What's the pathophysiology of stress as a factor or trigger of SCD symptoms?
See, stress in the body can be anything. Fever is a stress. Dehydration is a stress to the body. Similarly, any hypoxic condition, say the patient is in a high altitude area where oxygen levels are not. So all of these contribute to stress. All of this is stress to the body.
All right. Thank you, doctor. The next question by Dr. Tanda again, it's what's the management of priapism in SCD patients?
Okay, I already discussed it. So the management I can repeat for this is first hydration, control of the pain, and all supportive measures that are used normally for sickle cell disease, like oxygen, pain management, fluids. If it doesn't settle, we may need blood transfusions. And for those that are refractory cases, and definitely a urology review for any sort of urological intervention.
Okay, so the next question is SCD is not a disease. Why and how?
SCD is not a disease.
Yes, that's what's written in the chat. SCD is not a disease. Why and how? So
I don't understand the question. I think sickle cell trait, I had said, is not a disease, but sickle cell, disease has a whole spectrum. So sometimes they may not manifest with any problems. So it is not a disease, I believe. But once these pain crises and these manifestations start, then we definitely have to treat it as a disease.
what is the success rate of management of SCD vis-a-vis stem cell transplant?
So stem cell transplant has a very good outcome, especially when the children are younger. And even with a haploidentical stem cell transplant, we have reported good outcomes between 70 to 80% overall survival. And you've already seen the match sibling data that I presented, which was around close to 90%. So the outcomes are very good. It is a one-time treatment and the cure is for life. Whereas managing sickle cell issues is an ongoing process, and I think it is always one after the other. A lot of times, like I discussed, these overt or the hidden cerebral strokes are happening, the ischemic events are happening, leading to cognitive behavioral issues, which doesn't look like an issue initially when the child is young, but slowly takes a toll on the brain, the function. So I think it is very important that even if we do everything for these children, definitely some cognitive dysfunction occurs. So I think transplant is a much better option, and also doing it at a younger age.
Great. Thank you, doctor. Another question is by Dr. Epier, and he's asking management of vaso-occlusive crisis in sickle cell disease. Is there a curative treatment for sickle cell disease? If yes, then what it is?
So I discussed the treatment of vaso-occlusive disease crisis, and there is again no definitive treatment. We only have to support. We have to support with oxygen, with fluids, with painkillers, and possibly if it is excessive and not being controlled, with a blood transfusion.
Aparna, can you translate this in French because this was asked in French?
Yeah. Alors, il n'y a pas vraiment un traitement définitif pour cette pathologie. Soit on peut avec soutenir, juste avec les soutiens, les oxygènes, les fluides, etc. Et aussi des gélules pour atténuer la douleur. En tout cas, si il y a un niveau un peu excessif, on peut avoir recours à la transfusion sanguine.
Great, thank you. And another question is, under what age is stem cell transplant effective?
See, there is no age. We have transplanted adults as well. Only thing is that the risk increases with age, and the outcomes are obviously not that good. But otherwise, and definitely with age, the risk of stroke increases, the risk of the liver getting affected, the kidneys getting affected, all the major organs. So once those get affected with age, the chances of being eligible for transplant also reduce. So that is very important to understand, that transplant can be done at any age if all the organ systems are fine. But the outcome is not going to be as good as if it is done at a younger age.
So another question, it's asked in French again. The overall cost of, this is related to your hospital, doctor, in particular. This is the overall cost of bone marrow transplant at your facility.
I told you in the beginning also, so if it's a matched sibling donor, if we have an HLA matched sibling, it is somewhere between 20 to 24,000 US dollars. Whereas if a matched sibling is not present and it is a half matched transplant, then the price goes up to around 35.
And again, by the same doctor, it is the role of urine alkalization in the management of vaso-occlusive crisis.
So I think I mentioned this with respect to the kidneys, and alkalinization of urine always prevents any acidosis. It prevents infections, and once the urine is alkaline, any crystallization is prevented as well. So I think it overall helps with the pain.
Okay, Aparna, can you translate this?
Yeah. Alors, la place d'alcalinisation, c'est important parce que ça aide à prévenir des infections. En tout cas, une fois que l'urine est alcalinisée, ça aussi prévient empêche des cristallisations de l'urine. Donc, c'est important. C'est la place.
Thank you. Another question is in the chat. It is, what is the management of sickle cell in pregnancy?
So quite an interesting question. Once they are pregnant, hydroxyurea cannot be given for the first 3 months, which can be challenging because so we have to make sure that the patient is well hydrated, remains warm, and we try to prevent all sorts of crises. Through the pregnancy in the second and third trimester, one can start hydroxyurea if required. Transfusions can be done if required, and I think the patient can be delivered. The morbidity, mortality is high. I think every patient should be explained before they decide to start a family that the risk of for both the mother and the baby are quite high, because if there is a crisis during labor, during childbirth, it can be quite difficult to manage. Yeah.
All right. So I think we have answered all the questions. Is there any question like any doctor would like to ask right now? Aparna, can you please translate this in French?
Est-ce qu'il y a des médecins qui veulent poser des questions? On pourrait répondre aux questions. Qu'il y a des questions?
Doctor, you're not audible.
Yeah, I would want to ask, still applying protocol for the management of sickle cell in immunocompromised patients.
Doctor, we are not able to understand.
On comprend pas.
Is there any outline protocol for the management of sickle cell in immunocompromised patients?
I don't think so. Can anyone else understand the question?
Quelqu'un peut comprendre cette question? Parce que il n'est pas audible.
I think we've answered his question. Dr. Sunday Uncha has written, what is the management of sickle cell in pregnancy?
Outline protocol in the management of sickle cell in immunocompromised patients. Immunocompromised patients.
Doctor, can you please write it on chat?
Est-ce que vous pouvez écrire sur le commentaire?
Okay, let him write in the chat. I think we've answered his question previously. Okay, there is another question. SCD in pregnancy should be a multidisciplinary approach. And the pregnancy needs to be well supervised by a gynecologist specialist. Thank you. He's thanking you and just adding a few certain things. Thank you, Dr. Ratanda, for the insights. So Dr. Sunday has written that management of sickle cell in immunocompromised patient.
Allô? Allô?
Hello. Yes, doctor.
Moi, c'est Docteur Ntumbi. Je suis en RDC. Je voudrais savoir quel peut être un remède symptomatique pour un drépanocytaire qui n'a rien que l'ictère, hein? Surtout l'ictère oculaire, un ictère franc. Il n'a jamais été transfusé, il n'a pas de crise hémolytique, mais juste par moment des crises vaso-occlusives. Mais c'est plus l'ictère. Est-ce qu'un pareil enfant est éligible à l'hydroxy, disons au traitement symptomatique, l'hydroxyurée? Voilà ma question.
Est-ce que, docteur, est-ce que vous pouvez écrire sur le commentaire une fois, s'il vous plaît? I think she's talking something about the kids who have never done blood transfusion and whether they need to resort to the Uroxy, the solution which you had mentioned, something about that, something about the treatment.
Okay. So,
Est-ce que vous, I don't know if she's there.
Bon, est-ce que je peux, Nifisque, savoir quel traitement symptomatique en cas d'ictère persistant, ictère seulement, quel traitement symptomatique?
Symptomatic, which treatment symptomatic? She's asking.
which treatment is symptomatic?
Quel traitement symptomatique, pourquoi?
Contre l'ictère, ictère des yeux, l'ictère qui est franc chez l'enfant.
L'ictère.
Oui.
Can you write the question, please?
Exactement. Je peux pas exactement déduire. I'm not able to get exactly what she's saying on the audio.
Dr.
Okay.
It would be great if you write the question in the chat so that we can address it to you, answer it for you.
Madame, pouvez-vous écrire sur le commentaire? Icter. Icter. Okay. She's talking about the jaundice.
Okay.
Chronic jaundice.
Yeah.
About the symptomatic treatment for this jaundice, which is very chronic. Icter.
So, see, this jaundice you have to explain to her is happening because the red blood cells are breaking. So it really doesn't affect because it is chronic and these red cells will keep breaking. A lot of the patients will have a high bilirubin, but we cannot do anything about it. I don't know what her question is, but I think the hemolysis, we can just reduce that by starting hydroxyurea. But jaundice per se does not affect. Most patients will have a high bilirubin. I'm sure she knows maybe the question is something else.
No, it's written in the chat as well. It's related to, I also translated it in English. It's related to chronic jaundice.
Yeah, she's relating to chronic jaundice.
So you can explain to her that if there is chronic jaundice, we have to find out the cause by checking hepatitis B, C infections and finding out, doing other blood tests to make sure that the jaundice is not due to any other infective cause.
Okay. Do you want me to tell it out or should I just write on the chat? That would be better.
I think that will be better.
I'll write in French in the chat itself. Yeah.
Find out another infective cause for jaundice, like
Yeah.
hepatitis B and C.
So, in the chat, Dr. Morris has written the questions we have asked have not been responded. Doctor, I'm sorry if I missed out on any question, but I tried going out for all the questions. Let me just check once. Doctor, can you write your question? Dr. Morris, can you write your question on the chat so that we can address it? So there's this question, Dr. Dev, from an epidemiological point of view, what makes Africa more affected than other countries in the world?
I think the whole geographical distribution is just a genetic basis. Certain gene pool has that gene mutation. So that is what it is.
Aparna, can you translate that?
Can you just repeat? Sorry, I was actually typing.
He's asked the epidemiological, from an epidemiological point of view, what makes Africa more affected? I think it is just a single gene mutation. So it is the genetic pool, depending upon the geographical area, the genetic pool. So they are more susceptible to have that gene mutation and have that particular disease.
Okay.
Aparna, can you translate that so that
Yeah. Il s'agit vraiment, comme on dit, de mutation d'un seul gène qui est responsable selon la géographie, la localisation, donc qui s'adapte à cette maladie. Donc c'est vraiment la mutation d'un seul gène. C'est toutes les choses sont liées à la gène, en dépendant de la localisation.
Great. So, and here's the last question, Doctor. What is the role of consanguineous marriage in sickle cell disease?
So, as I had already mentioned, the inheritance is autosomal recessive. So when there are consanguineous marriages, which means that the husband and wife or the two partners may be related in some which way, the chances of both parents being carriers are quite high because it may run in the family. So when the two parents will be carriers, the chances of having a child with sickle cell diseases obviously goes up to 25%. So that's why people who have consanguineous marriages, the risk of autosomal recessive diseases increases.
Great. So I think let's conclude the call. We don't have more questions. Most of the questions that we had also, like in the forms that we received, were already addressed by you, Dr. Divya. So that's all from our end, and a very heartfelt thank you to Dr. Divya for such an incredibly insightful and enriching session. And we really, truly appreciate the time and effort you dedicated to make this session so impactful. Thank you. Thank you so much.
Thank you. Thank you.
Aparna, can you translate this in French?
Oui, oui. Merci beaucoup, Dr. Divya, pour votre temps et pour investir beaucoup de temps pour donner vos idées et transmettre vos connaissances sur ce sujet. On apprécie beaucoup. Merci.
And thank you so much to all the African doctors for joining us on time and staying with us for 1 hour, 40 minutes. Thank you so much. And thank you, Dr. Divya, for taking out extra time for answering all the questions and addressing all of them. Thank you.
Thank you so much. Bye.
Thank you.